So let us move to the next section, which is environmental factors in the operating room. Now, one of the most important factors that we have is temperature. And for the operating room in which we are operating on adult patients, the ambient room temperature should be between 20 degrees centigrade to 24 degrees centigrade. And this actually is the cost versus benefit compromise. This pressure range, this temperature range is because we have our surgical crew, which is usually standing just below the lights and which has heat, and they have their surgical garbs on, and this may make the team really uncomfortable. But we cannot lower the temperature more than this required range because that would then lead to hypothermia, and hypothermia has certain effects in the patient. It could lead to wound infections. And how would it do that? It directly directly affects the function of neutrophils and T cells. And we all know that neutrophils are implicated in acute inflammation, right? And so, because we have this our impaired immune response, so this would lead to wound infection now, right? And how what could be the cause of impaired coagulation? The reason is that there is a decrease of thromboxanes A2. We all know the whole mechanism of the platelet plug formation. Let me review it very quickly here, so that we have tissues or vessels. When there is an obliteration, the underlying collagen uh, it becomes accessible to platelets which are flowing in the bloodstream, and then it leads to formation of von Willebrand factors. Not formation of, they are already in the granules, just there is a von Willebrand factor. It binds to GP 1B and 3A receptors, and this leads to clumping. And platelets themselves, and there are certain other conformational changes which I will not go into. And then from COX1, COX2, there is formation of thromboxane A2 and what else? EDP, which again leads to the conformal change in the platelets, and this causes platelet plug formation. So this whole system, this is impaired in hypothermia, and this leads to again greater intraoperative blood loss. And through other morbidities, it can also cause prolonged hospitalization. And there is another whole chapter dedicated to this thermoregulation, and we'll discuss more of it when we come to it. Now, the other important factor which constitutes the environment of OT or OR is humidity. So usually in previous days we had ether, which were used as anesthetics, and those were highly inflammable. So this was the reason why humidity had to be maintained, because when in lower humidity states, this would result in static electrical discharge, and that would ignite ether or chlorhexidine. But now in these days, humidity control is more relevant to infection control practices, because uh, this is the range that we have, 20 to 60% humidity. This is what we want in an OR. Below this range, dry air would facilitate airborne mobility of particulate matter, and then that matter could lead to infections. And at high humidity, this could cause dampness of the drapes or sterile cloth, and this could again affect our uh, sterile barrier that we have encased our patient in. Another important factor in operation room environment is ventilation. Operating room is ventilated by blending 80% of recirculated air with fresh air. And we have to make sure that this flow, let's say for example this is our operating room, and imagine it to be our operating room. And so we have circulating air. It enters through somewhere from the top and it leaves by somewhere a vent at the bottom. So this is how air should be flowing, and it should be all linear. If it is turbulent, it means that effectively this could not be done. Effectively, fresh air, we will not be sure whether fresh air is there or not, because it would be recirculating in small torrential flows. So we have to ensure that this is unidirectional and non-turbulent. Although recirculation conserves energy and cost, uh, but there is a huge turn down for the wedge that we have discussed already. Because if 80% of the air is recirculating, we know that this would also constitute waste anesthesia gases as well. So this is why a separate waste anesthesia gas scavenging system needed, and this is it's applied to almost most OTs. Wedged as a lavender scavenging system is not that common, but there is some sort of a ventilation system for anesthesia gases present in operation room. Now, operation room should also maintain a slightly positive pressure to drive away gases that escape scavenging, right? And should be designed to so fresh air introduced through or near ceiling, as we have already discussed here, and handle that or uh, vented out through the floor, right? Ventilation consideration must address these both things. First is air quality, the quality of the air and the volume changes. Now we have an organization which is called an NFPA, which is National Fire Protection Agency. This is actually a non-profit organization, and it deals with certain safety issues when it comes to occupational health, occupational hazards, which constitutes our OTs, operation rooms as well. So it recommends that there are 20 air volume exchanges per hour should be done, and according to the studies and manuals of NFPA, this decreases the risk of stagnation and bacterial growth, right? And now there is a 90% filter that is used. Now this is a requirement. This should be done in an OT. And what is the 90% filter? 90% filter ensures that 90% of the particles that are being presented to that filter, they are filtered out. Now this is not the most effective or the efficient filter, but this is the one that is required. The most efficient one is HEPA filter, which is high efficiency particulate filter, and this is made up of this meshes of crisscrossing fibers, and they can very effectively uh, filter out a very small particulate matter, and that would be around less than even 0.1 micrometer. Then this is really small. Now, noise. Multiple studies have demonstrated that exposure to noise can have detrimental effect on human cognition, uh, cognition as well as prolonged hearing. Prolonged exposure to great levels of noise can also lead to hearing impairment. And 72 the operating room noise level, it exists between 70 to 80 decibels, and with frequent sound peaks exceeding 80 decibels. So this is an average, actually time weighted average that we see. Let's say for example this is the OT hours. It starts at 0th hour and then it works for the 8 hours, and then we have the peaks in which it is the peak that we record every hours. So we see that frequently they occur at uh, eight close to 80, and some of the peaks they also, if this is the 80 dB cutoff, then we know that some of the peaks they also frequently exceed this 80 decibel cutoff. And we know that most of the peaks are around 80 because the weighted average is approximately uh, 80 dB. And what do we mean by 80 decibels? 80 decibels is because there is this organization, Occupational Safety and Health Administration, it regulates and monitors this uh, limit. And according to the definition of OSHA, what it says on the in their website is because is that if there are two people and they are 3 feet apart, and if person one has to speak a little louder on increase the conversational voice, then it means that the ambient noise is around 85 decibels. So this is how we can get an intuitive feeling of what an 80 decibel would be. And in operation theaters, we have some certain equipment such as orthopedic ear chisels and neurosurgical drills. They can approach a noise level of 125 dB, 125 decibels, and this is the point where most human subjects begin to experience pain. And this is the reason why OSHA requires hearing protection in OTs. Now, in some of the OTs, in modern OTs, we have ionizing radiations as well. In more and more uh, orthopedic procedures, we have an equipment which is called a C-arm, and which is actually an X-ray machine. Now, most people also are not sure about what ionizing radiation actually is about, and in the media and everywhere else, we hear that mobiles have radiation and microwaves have radiation, and they can. And we also see that they are being linked to the effects which are usually attributed to ionizing radiation. So, what actually is ionizing radiation? So, let me start. Let me explain it just quickly. So, we have in the Rutherford model of an atom, we have this core which has protons and neutrons, and then we have surrounding that core we have electrons. Protons are positively charged, neutrons are neutral, right? And in certain cases, what happens is that this core, the internal core, is unstable, and it gives off radiation until it becomes stable. And that radiation, most of us know, some we have studied that in school, that it can be alpha, beta, and gamma radiation. Beta is usually an electron, alpha is the component of proton neutrons, and gamma is again our radiation, right? So we have this is the radiation that we have. And what radiation has an ability is that it carries an energy of the sort that it can knock off electrons uh, of molecules, and this can destabilize biological molecules. And DNA is one such molecule, and if this DNA is disrupted, this could lead to effects that we can see in as uh, cancer. As we know that cancer causes ionizing radiation causes cancer. It can, in small doses, called skin erythema, cataracts, right? Now, some of this cancer, for example, is a stochastic effect, and some are deterministic effects. These are two types of uh, effects of ionizing radiation. The deterministic one is given a dose of ionizing radiation, this is going to happen. We'll see that through our eyes. But a stochastic is a random one or a probabilistic one, because if I give radiation to about 100 people, approximately 10% would get cancer, right? So this is not deterministic one. So these are two types of effects that we have, and this is the reason why we have certain units that we have in ionizing radiation. We have grays, we have reds, but we talk about sieverts, and Ronja equivalent in man. This is pronounced Ronja, and Ronja was the person who actually discovered uh, X-rays. And the story is also very interesting. You can Google it if you'd like. And so, what actually is gray? Gray is actually joules per kg. We write it gray, and gray it actually is the amount of ionizing radiation per kilogram of uh, any matter. This could be human matter as well. But as we know that because of stochastic effects of radiation on the humans are different, and because eyes are affected, thyroid is affected, gonads are affected, and not all cells are affected by radiation. So we know that because of different organs take up this energy differently, and they also display the effects of radiation differently. We cannot use one unit to uh, quantify radiation risk in every organ, right? Because gonads would have a different threshold for biological effects. So this is why sievert was invented. Sievert is actually a unit of radiation that multiplies effective dose by the weighted average, right? Weighted average of tissue, right? So gonad would have, let's say thyroid would have, for example, this is just an example, 0.03. Gonads would have, right now they have 0.08, but they used to have zero point 0.2. So these factors, when they're multiplied, they would portray the real uh, effect of radiation that we have on our body, and how this affects them. Now, can you notice why it is only these organs which are affected, like eyes, thyroid, gonads, bone marrow, blood, and the fetus? Because if you note that these are the one where active cell division is occurring, and active cell division means that DNA is being replicated, and when DNA is being replicated, it means the errors of replication are more. So these are affected more. Radiation can cause cataracts because of disruption in the DNA of these cells, right? So sievert is the new uh, unit that we have, but in the olden days we had Ronja equivalents in men, and this is sometimes also used. And for people who are working in setups where there is radiation, and they are required to wear these film badges, which has some photographic films, and this shows how much radiation they have received over a period of time. And uh, the radiation badges should be worn routinely by anesthesia providers as well, because for those especially those providers who work intermittently in areas where fluoroscopy or other ionizing radiation devices are used. That would be your radiology suits, or gastroenterology suits, where you have working fluoroscopy done in almost tandem. Now, lifetime exposure can be tabulated by a required database of film badge wearers. Now, we have some film badge wearers, and we have their data and how much they get in a unit time, and we can always extrapolate it to how much lifetime risk they are going to have. So, a basic principle of radiation safety is to keep exposure as low as reasonably practical. We term it as ALARP, right? And the principles of ALRP, they constitute time, distance, and shielding. First of all, the time of radiation should be decreased. We can do that by reducing the time of procedures, reducing the time fluoroscopy is being done in operation theaters. And the second is distance. Radiation exposure over distance follows the inverse square law. And what does this inverse square law means? It means that over a distance, radiation of any sort, I'm going to term it with R, it quickly decays, right? So let's say, for example, if it is 100 millirads at 1 centimeter, at 100 centimeter it would be only 0.01 0.01 millirads. So it will quickly decay. So if you, in terms of fluoroscopy, if it is being used in about 7 feet, it would become almost near to zero. So shielding is the most reliable form of radiation protection. We know that we have lead aprons in operation rooms, and we also have thyroid collars, and we have glasses which should be worn. And there are also physical shields that exist in gastroenterology and radiology suits. As use of reliable shielding has increased, the incidence of radiation associated disease of sensitive organs has decreased. Now, this is universally true except for radiation induced cataracts. And the reason is because of non compliance. This is what actually the textbook quotes.